Hello, my name is Justina Bianco, and I am an Azusa Pacific student for the Inland Empire campus in the entry-level Master's of Nursing and Nurse Practitioner combined program. For my project, I really wanted to focus on where we are now today in 2022 in regards to responding to the COVID pandemic, and not only from a lens of providing patient care, but a step further beyond that of the psychosocial aspects for not only the patient, their family member or caregiver, but also the nurse. So for my project, I looked at the utilization of pre-discharge education and post-discharge peer support recovery clinics for the prevention of post-intensive care syndrome. And basically, this is something that they're finding with patients from long-term COVID and also patients who are going to critical care environments for diagnoses non-COVID related. So what it's really assessing is the psychosocial health of the person who survives a almost near death experience and has to go into critical care, and what that looks like for them long term. So what's been brought about into recent literature is that there are these negative impacts on the physical, mental, and cognitive health of not only the patient, but their caregivers and nurses. So for my problem, I really wanted to look at what was going on in the hospital as far as the pre-discharge process. Are they, and when I say they, I mean our healthcare providers discussing what PICS is, and also are they educating them about resources available for once they do get discharged so that they can utilize those resources in their community based clinics to decrease risk factors and in developing PICS to prevent it. So again, the problem is not only the pre-discharge, but the post-discharge. And when it comes to looking at who's greatly affected, it's not only the patient that survived the care, but it's their family member or their caregivers who are on this recovery journey with them, who saw them in this state, who came to the hospital, who now has to make sure that they're following up on their care and that they're reacclimating to society in a way that that best empowers them. And then also the healthcare providers. So the increased demand of patient care from 2020 to now, and that psychological stress that happens to nurses who day in and day out have to face these near life death experiences and process them so rapidly to be able to even continue working and make it through the shift. So what is their health and what are the long-term effects of working in healthcare, especially nowadays with this increased demand of critical care patients and this as the COVID variants continue to rise, this extended pandemic. So what does it look like as far as not just their burnout of wanting and being able to come to work, but like their own quality of life? So my research question is, what is the effects of the hospital-based pre-discharge teaching for nurses, ICU patients, and their family members, along with post-discharge treatment at community-based peer support recovery clinics compared to nurses and ICU patients and their family members who do not receive pre-discharge teaching and post-discharge treatment at community-based peer support recovery clinics in regards to affecting the risk factors for developing post-intensive care syndrome. So my hypothesis is by systematically implementing a pre-educational discharge for the nurses, the patient, their families, to let them know what PICS is, as well as how to decrease it and what available community resources are available for them to get treatment for recovery once they do leave the hospital, that pre-discharge intervention of education, along with the treatment in these peer support recovery clinics, will decrease the risk factors for PICS, which again, not only affects the physical, but the mental and the cognitive health of people, and also their quality of life and ability to return back to whatever their normalcy was, whether they had a career and they were working, or, you know, being able to carry on their life in a way that they find value in and feel empowered to do so after this experience in a critical care environment. So my PICO, my participants are the ICU nurses, ICU patients, and their family members or caregivers. The intervention is of two parts. So internally at the hospital base, there's an intervention of pre-discharge. So what PICS is, what are the risk factors? And then post-discharge, there's an intervention of treatment at a community-based recovery clinic. So this is, again, in their community, post-discharge support. And so I'm comparing them to basically nurses, patients, and their family members or caregivers who don't have any pre-discharge education about what PICS is and what resources are available, and therefore also no treatment at a local community-based clinic for recovery. And so the outcome is to decrease the risk factors to prevent PICS syndrome, so that over a time period of 3 months post-discharge, when the evaluation is conducted, it will show an improvement in their quality of life using various validated tools. And so my design is a quantitative study design survey, and I'll be conducting it using a casual, comparative, quasi-experimental research approach to measure how the educational pre-discharge intervention went and if it was well received on, you know, what PICS is and the resources available at local community clinics, as well as the post-discharge intervention of accessing peer support in their community. The review of literature, there was I used various APU databases, and I really found that PICS is something that was kind of in the academic conversation around 2012, but since the pandemic has hit in 2020, we can say the like peak of it more so. They're showing that these resources, as far as peer support, community-based clinics worldwide, from the UK, Australia, to Scotland and the US, they're showing that this is an area to really further dive into and evaluate, because prior the need wasn't as great as it is now to find some way to continue to care for patients as they survive these times that we're in, and really to address the gaps in care and the continuum, and not only for the patients, but again, their family members, their caregivers, and also the nurses, the interprofessional team that is coming together to ensure quality care is given. You know, we also have to look at what is their mental health, what is their quality of life looking like for them to even continue to show up, and to also have quality access to resources to support themselves on their own recovery from the provider perspective and lens in the care. So for my critical appraisals, the first quantitative article by Dinesh from 2022 really looked at the characteristics of post-ICU and post-COVID recovery clinics in 29 US health systems. So these clinics, again, modeled the peer support intervention, but one specifically was for post-ICU, so post-critical care, and the other was post-COVID care. So one looked at if you had the COVID diagnosis, that you get to one clinic, and the other was just any kind of critical care. So I really loved this study because it was the evolution of all the work that's going on. Basically, it was a cross-sectional study, and it looked at it through gathering quantitative surveys online to evaluate the critical and acute illness recovery organizations post-ICU clinic collaborative peer support clinics. So this just basically developed building on the Thrive collaborative approach, which was made prior to the pandemic. So this has now taken the peer support intervention and looked at it in a lens that's inclusive of all of the different variables that we're now facing in 2022. According to the Johns Hopkins appraisal tool, this study scored a level 1A for the reliability and accuracy. And the second quantitative study that I included was by Haynes, and this was from 2019, and it looked at the key mechanisms in which post-ICU activities and or can improve ICU care. And so this looked specifically at the Thrive initiative that I mentioned earlier. And so this was a qualitative inquiry that focused on groups and interviews with persons at different sites to really address, what were the key mechanisms. And so based on the Johns Hopkins tool, this evidence-based tool, the study scored a level 3B for reliability and accuracy. When it comes to my qualitative appraisals, PICS 2021 study was amazing. It basically looked at the benefits of peer support for intensive care survivors and shared their experiences and care debriefing and altruisms. What I loved about this is it was so inclusive of the intersectionality that goes into, what is someone's quality of life. Again, everyone has their own definitions, their own values, ideology on what gives them joy or gives them like happiness and fulfillment. So to really gather surveys from people who have gone through different peer support programs and being able to share their own perspective. So this was from the family members, the caregivers, and the survivor, the patient, to share what their time in the peer support recovery clinics post-discharge did for them and how they felt seen, safe, and heard. So this was really valuable. And according to the Johns Hopkins based practice tool, this scored a level 3B for reliability and accuracy. And then another qualitative study I included to really encompass the interprofessional care into this conversation was by Kim of 2022. And so this looked at the burnout of public health nurses during COVID-19 pandemic and the mediating effects of perceived health status and perceived organizational support. And so this was crucial piece because I think without organizational support, nothing is possible. And to really look at what are the frontline responders' mental health looking like, what it's looking like, as well as what is their advice. We can't make a program without bringing in all the stakeholders. So this study was a cross-sectional descriptive, and it was used through questionnaires and explored the associations between the emotional level and then the perceived organizational support of public health nurses during the increased demand of the COVID-19 pandemic. And based off of the Johns Hopkins nursing evidence-based tool, this scored a level 3A for reliability and accuracy. For my implementation strategy, I plan on conducting a pre and post project where the goal will basically be to, again, intervene pre-discharge with patient education on what PICS is, the risk factors, and what available resources are for them to receive treatment at local community-based recovery clinics. And then once they get discharged, there will be this treatment at the community-based recovery clinic, and 3 months after they begin treatment there, there'll be the post evaluation. So the results will be measured using the 27-item Healthy Aging Brain Care Monitor self-report, which is a validated clinical tool that captures all 3 domains of the post intensive care syndrome. Again, I mentioned it's physical, cognitive, and mental. So this will capture that. And then I'll use the robust implementation and sustainability model framework to assess the effectiveness of the pre-discharge educational intervention on the participants, to teach them about what PICS was, and also the risk factors and what available resources are out there for them to receive the treatment at the peer support recovery clinics. For my data collection and tools, it will be a descriptive statistics to evaluate the survey findings of the Healthy Age Brain Care Monitoring Self-Report, and as well as the pre-discharge teaching using the robust implementation and sustainability model. And this will be then evaluated using Conbrandt's alpha score to measure the reliability using a value greater than 0.70. And then some ethical concerns and considerations are the functionality of the ICU patient and their functional ability pre and post ICU discharge across the intra and international transition levels involved in the continuum of care. So again, what did they look like before they got sick? What was their life? What were their social determinants of health? What was their access to care? And then once they did get sick, not just the patients, but the nurses, once this impact of and this increase in patients, how did that affect them? So where were they before all of this, as it happened, and then afterward? So it's really easy to say we have a text box patient who had great care and then this happened and now we're looking. But so the ethical considerations are, we already know healthcare in the US is not perfect, and that there are barriers and gaps in access due to so many measures, specifically, socioeconomic class. And as we now look at this data, it's important to think about what the person was experiencing prior to these added stressors and variables, and then to take all of that together in order to address the gaps and to improve the continuum of care. So again, to look at the person as a whole and what they were going through psychosocially prior to the illness and receiving care in a critical care environment, regardless whether it was related to COVID or a different critical health issue. So what that looked like for them, as well as their family or caregiver, and for the interprofessional team now that is, continuing to deliver care at such a great demand and pace. So in conclusion, since the COVID pandemic is still ongoing and we're finding ourselves now in the second year, some might say third year of it, the world is in the position to really get creative and have a revolutionary design of what quality healthcare looks like. And with these added stressors and variables on not only the patient, but their family and caregiver and the interprofessional team, specifically nurses, it's important to not only address the physical, but the mental and the cognitive health, and to provide psychosocial support and really implement that on an organizational support level within the healthcare system to prevent the risk factors for developing post-intensive care syndrome, and to utilize this model of community-based peer support recovery clinics post-discharge as a solution to decrease the long-term negative effects on the cognitive, mental, and physical health of all ICU survivors, their family, caregivers, and ICU nurses. Thank you so much.